Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Hello, and welcome to TCN Talks. Our guest today is Peter Benjamin. He's a well-known consultant. He's also a partner with the Huntington Consulting Group. Welcome, Peter. It's good to have you back.
Thank you, Chris. Fabulous to have another chance to chat with you and your listeners.
I always value our time together. But before we jump in, what does our audience need to know about you?
I think all of us are the product of our experience, so I think it's fair for folks to know the backgrounds of speakers so they can appreciate where our biases may come from. I've spent my entire 45-year career in healthcare. Interestingly, that's almost an exact mirror of the history of hospice in the United States. I've spent 5 years full-time engaged in hospice in the early 90s, and the rest of my career anywhere from 20 to 70% involved in hospice. And I tell your listeners that because I think at some level I'm an inside outsider or an outside insider. I think hospice has played a very important role in my career and engaged me intellectually like nothing else I've done. But I also think I have a perspective from outside of hospice, and I think particularly where we find ourselves today in the hospice world, that's an important perspective.
That's 45 years. Dang, that's why you're so dang wise, I guess, right? I maybe didn't pick that up the first time, but that feels pretty profound. Well, Peter, what I love about you is you provoke my thinking. I feel like you're a good provocateur. There are probably a whole lot of other good adjectives I could use, but I do appreciate that about you because you really do make me think and you make me question. Either I get down to bedrock of why I really believe something or you make me rethink it. So just that's all my ways of giving you kudos. So as I thought about what I want you and I to talk about today, I just thought it'd be good to start. Like, what's your general advice about where things are headed? And then also how hospice and palliative care programs need to position themselves to be relevant and thrive into the future.
I think we're at an inflection point as community-based hospice providers. I don't mean that as a parallel to technology businesses where a technology comes and immediately displaces or antiquates something else. So I don't mean inflection point as a literal, the switch will be flipped kind of metaphor. But I think we're going through a 5 or 8 year inflection point where after 40 years of a one-size-fits-all benefit, the market has and continues to evolve. When I think of the late 70s and the demonstration project, and I think of congressional testimony, which I recently reread for somebody for some reasons we don't need to get into. And when I think of the benefit passing in 1983, the hospice benefit was designed for cancer patients who had caregivers and could and wanted to die at home. That's an oversimplification, but directionally correct. It certainly didn't envision people dying in assisted living because no one did. People literally didn't even start to die in assisted living communities until the early 2000s. The original benefit didn't envision people dying in nursing facilities. That round peg was squeezed into a square hole in the late 80s, early 90s. And so we find ourselves today serving most of the folks in the hospice marketplace in ways that were not designed inside the original hospice benefit. Then we can talk about how the rest of the healthcare world has not just evolved, but radically transformed itself. And so on the one hand, I say to colleagues all the time, there's never been a better time to die in America because I think people at end of life have access to better, more comprehensive, more expertly provided, more caringly provided specialized services than ever before. But two things can be true at the same time. I think it can both be the best time to die and not good enough. And I'm optimistic that disruptive innovation provides benefit for almost everyone and unfortunately provides potential cataclysm for incumbents. But incumbent providers are the minority. The rest of the society is the majority. So disruptive innovation has been part of our economy, a little less so in healthcare, but increasingly so in healthcare. So that's where I think we are.
Can you unpack a little bit more about cataclysm for incumbents? What do you mean by that?
I think historically, inside and outside of healthcare, business historians, business school professors would, without emotion, stipulate that innovation rarely comes from incumbents. That's not to say never. I didn't say that. I said rarely. And again, you can do unemotional examples outside of healthcare. We can take examples closer to home. It wasn't hospitals that pioneered outpatient surgery. Oh, how shocking. They were the ones that were going to be disrupted. So they were not, in fact, the innovators and pioneers. And yet you barely have to drive a mile or two from your house today to find an ambulatory surgery center. And I think those kinds of examples are instructive for us meaning 40-year plus hospice leaders. And so I'm both cautioned by those examples and enthusiastic about the improvement for recipients of care from innovators.
And there's so much. You're being very precise with your language. I love it, actually. And there's so many cool tangents we could go, but I'm going to go with our main line of questioning here. What are some of our substitution competitions out there for hospice and palliative care leaders that you feel like, hey, you got to be aware of this?
I think we have beginning examples. So the good news is I'll give you some. The better news is I don't think this chapter has been written yet. So I think for our colleagues, for hospice leaders around the country, the decisions are going to be around, are we willing to disrupt ourselves? Are we willing to think more broadly than perhaps we have in the past? So I mentioned a couple of moments ago, the original hospice benefit was not written for folks that live in, let's just call it senior housing, whether that's independent living, assisted living, nursing facilities. And I think over the next decade, we're going to see a real metamorphosis in how all care is provided there. So this is not a hospice end of life thing at all. I think we're going to see, for the 3 to 4 million people that live in senior housing, an explosion in opportunities for them to receive more holistic, team-provided, patient-centric care. How interesting. I think those are words and phrases all our hospice colleagues would use to describe what we do, but have never really been characteristic of how residents of these communities receive all their care. And so I think, to our credit, I'm proud of all the things our colleagues have done. I think we have instilled in the system a sense that team, patient and family-centric care can have real value, not just in the last 60 days of life, maybe for longer periods of time. And so I think it's going to be incumbent on us, first and foremost, to really learn about these emerging models of care. What does Medicare Advantage really mean? Why are dual eligible special needs plans unique? Why are institutional special needs plans unique? What can we learn from PACE programs? I do a lot of work in PACE, and I don't want to offend my PACE colleagues by saying I don't believe that PACE programs are, quote unquote, the solution to all long-term care problems, any more than I think hospice is the solution to all end-of-life care problems. I think in both instances, PACE providers and hospice providers have forced everyone in our adjacent spaces to realize that the basic models of care we pioneered work. So I don't know that regulated PACE will be the thing, but I'm pretty confident that in 10 years, we're going to see a smaller percentage of people in nursing facilities because nursing home diversion programs, PACE programs, PACE-like programs are going to be fundamental to how fully integrated, highly integrated DSNPs work and succeed. And that's going to be better for the patient, better for their family. No one's waking up in either of our communities today, Chris, and saying, wow, I'm really excited about going to the nursing home. Okay, that's just not how it works. So I think it's incumbent on us first and foremost to learn. And that's harder than it sounds, because for us to learn means, what does it mean to run a delegated risk-taking physician group? What does it mean circa 2024 to be in the oncology world? What does it mean to run nursing facilities or CCRCs or assisted living communities? What does it mean to be in a multi-specialty practice taking delegated risk? Boy, it's never been harder to be a hospice professional because of all that's going on around us. And if you don't speak their language, then you don't know how to solve their problems. And you're likely to simply talk louder about what we have. And that's not generally effective.
So two things, because I'm thinking of all of our listeners. We do have hospice and palliative care staff amongst our listeners, Peter, and of course leaders, and even now board members. You alluded to SNP plans. Can you just give a quick little elevator speech and give them a snippet on what is a SNP plan?
Sure. Going back a few decades now, through multiple administrations, the Department of Health and Human Services and the Center for Medicare and Medicaid Services has been on a mission to push, cajole, persuade participants in our healthcare system to embrace value-based care. Value-based care, simplistically defined as, rather than paying folks for what they do, meaning a fee-for-service model, paying folks for outcomes and pushing risk onto the provider so that they have to both perform at an agreed upon level of quality and be at risk for that which they do, meaning you don't just get to do more, bill more, make more. And this evolution, led by the federal government, largely through the Medicare program, to push value-based care, created most recently what's called the Medicare Advantage program. And so when folks turn 65 or any time thereafter, if they're eligible for the Medicare program, they can decide if they want to voluntarily enroll in a Medicare Advantage plan. Think of it as HMOs meet Medicare. A little more complicated than that. But the premise is that over time, if Medicare is able to push, cajole, persuade participants in healthcare to embrace value-based, that there will be a long-term opportunity to save money. As the Medicare Advantage program has grown, much like we were just talking about the hospice benefit, the folks running it have come to realize, gee, the Medicare Advantage program was one size fits all. And we were designing something for all 66 million Medicare eligibles, and maybe inside that big cohort of folks, there's some unique cohorts that would benefit from specialized programs. And so the acronym SNP, or Special Needs Plan, came through Medicare's experience working in this big market of 66 million folks and responding to innovators saying, hey, how about if we design a specialized Medicare Advantage program, for example, just for folks who live in nursing facilities or assisted living, and that is the institutional special needs plan, or the variant of it, the institutional equivalent or institutional eligible special needs plans. So those programs are now serving about 130,000 folks that live in particular kinds of facilities. There's about 12 million dual eligibles, so folks who have both Medicaid and Medicare. And the federal government realized, gee, maybe just the, quote, normal off-the-shelf Medicare Advantage program doesn't work perfectly for them. What if we create a mechanism where the states can innovate with Medicare Advantage plans and be creative in how we take care of those 12 million folks? And so I think what we're seeing, consistent with our previous conversation, is evolution and innovation is everywhere in healthcare. And the one-size-fits-all model that usually starts things as time passes usually finds itself subject to some kind of segmentation model. And that's what's happening in Medicare Advantage.
That's really good. And just use another term that I think will be helpful to define, a delegated physician risk group. And I may have butchered exactly how you said it.
Sure. One of the trends over the last 3 decades, but increasing more geometrically than arithmetically over the last decade, is health plans deciding that the way they can work best with healthcare providers, so think of a licensed insurance company, whether a Medicare Advantage plan or a commercial insurance company or a managed care organization working with Medicaid, those organizations have concluded, gee, the way we can best partner with healthcare providers is to align our financial incentives. So if we, the health plan, are given a flat amount of money, immaterial of the services performed underneath it, then maybe the best way to get docs in the same boat with us, rowing in the same direction, is to align their incentives. So I'm just going to make up some numbers to be illustrative. So let's say I'm a health plan and I get $1 in healthcare premium a month. Historically, I then went out and contracted with folks on a fee-for-service basis. And I then tried to manage how I spent my dollar, mindful of the fact that if I spent more than $1, I had a problem because that's all I was going to get every month. And so the phrase delegated risk comes from the construct of the health plan saying, okay, I have my dollar and all the risk. Delegating risk means I, the health plan, am going to give you, Chris, and your physician group some part of that risk. I'm going to delegate some part of that risk to you. So for example, if you're a primary care group and you have 1,000 patients that you've become the primary care doc for, rather than paying you fee for service, I may give you 6 cents of my dollar and tell you, you don't have to bill me every time you see that patient. And some patients you might see a bunch and some patients you might not see at all, but I'm going to give you that 6 cents every month, immaterial of how many visits you make. By the way, all sorts of crazy things happened during COVID. That could be a source of a whole other conversation. Many innovative, I mean, as horrible as COVID has been, continues to be, I don't want to put any positive gloss per se on COVID. But there were, as in all crises, some learnings and evolutions and creativity that came out of it. I think an awful lot of physician groups figured out, you know what? Boy, particularly during the first 12 months of COVID, it sure was good financially to be getting a delegated risk payment rather than having to figure out how to see patients the old-fashioned way. And if I called them or we did Zoom, I was getting paid because I was taking delegated risk, so I wasn't subject to the old model. So lots of interesting things have happened that we never would have predicted or intended. Along these lines, Humana just recently, as in this week, announced the expansion of their CenterWell program. So Humana continues to aggressively employ docs, and they delegate risk to the docs in their own system. United has yet to deny this number. The last number that United publicly confirmed was that they employed 70,000 physicians. In the last 60 days, the number 90,000 has been thrown around in a bunch of different venues by Wall Street folks, others. No one has denied the number, so I'm willing to say I can't confirm it, but there's at least enough data points to suggest it's entirely plausible that United now employs 90,000 doctors. Both United and Humana, I'm just trying to connect the dots for you, often will have delegated risk contracts with freestanding physician groups, and if they perform well, will buy their practice. And so delegated risk also becomes a way that physician groups can demonstrate how they perform if they want to imagine a different financial relationship over time, like selling a practice.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our April and November 2024 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in the end-of-life and serious illness care.
That's a master class right there, Peter. Thank you. So I think you're painting a beautiful picture of there's these disruptive innovations. We're going to have to evolve. You've given us some really good definitions. So as people start to think about, okay, what do I do about that? It kind of strikes me, do I build, do I buy, or do I partner? And my guess is, and you may come up with a couple other flavors, but how do you counsel folks, like which one do I go? So I don't just get paralyzed by these things coming at me. And so how would you unpack that?
Yeah. I'll give you the sort of BS consultant answer, which is yes. Which
it depends.
Of course. But the real answer is, on the one hand, every client I've ever worked with starts a conversation with me by telling me how unique their program is and their local geography is. And I try early in our relationship to come to agreement about that, because we actually agree in principle and generally disagree as to the math. In other words, when I push a prospective client, they'll tell me, well, 80% of our organization and market is unique and 20% is like everybody else. And I push back and say, well, I think 80% of your organization and market is like everybody else and 20% is different. The reason I'm teasing that out is because, of course, local matters. Period, hard stop. But a delegated risk-taking group, a multi-specialty group, an oncology group, a senior housing owner-operator, the principles of how they operate their business are identical market to market. The local situations vary immeasurably. There can be 5 health systems in a market or 1. That creates a very different competitive dynamic. But the business model of the health system or hospitals is the same. So I think the first step, Chris, is our colleagues have to simply understand the business models of our healthcare colleagues better. That means our hospice can't engage with the now 100-person delegated risk-taking multi-specialty practice down the street by simply saying, I'm here, do you have any hospice referrals? We need to know what's the actual strategy of that group. We need to know the business manager as well as the person who handles hospice referrals. We need to understand their contracts with payers. That's often a very different set of interactions. It may or may not fit the competence of the person we currently have relationship managing that organization. It may involve the CEO. It may involve a board member. It's a complicated map. But as our referral sources and business partners, businesses have evolved and become more complicated, we're behind. I'm judging, my experience is our colleagues don't understand where our customers are as well as they did 10, 20, 30 years ago. So I think this construct of do I buy, build, partner starts with I have to understand my local market. And yes, every local market is different, but the business model of these entities is not different. And so you're not starting from scratch, whether you're in Asheville or Charlotte or Raleigh. You bet the local markets matter. But I think we sometimes get a little more wrapped around the axle on that than we need to. Then I think you can find, well, what does it look like in your market? Are there DSNPs now? Are they coordination only or highly integrated or fully integrated? What does the institutional special needs market look like? And we may or may not be able to own interests in any of those businesses, but I don't think we're going to have a clue what makes sense until we fully understand who the incumbents are in our geography and adjacent geographies. The insurance market tends to be very state-oriented. So if I saw that, for example, there was a new health plan that was doing I-SNP and D-SNP in Charlotte and Raleigh, I'd be pretty confident that wasn't their end game. I'd be pretty confident they were going to look at expanding throughout the state. And so, again, when we define our market as a hospice, particularly ones with CON or CON histories, we tend to think about county zip codes the way we've been regulated. We have to think differently when we look at our customers and how they look at geography and maps and their business model.
That's really good. Well, and I thought about asking you this question, and I think it's even think it's a better question even now, because I think you have such a unique purview, Peter. So if you had a loved one that needed some type of serious illness care, let's say it's a very close family member, knowing what you know, how and where would you steer them?
So that's not a hypothetical question. I get a call like that at least every month. My wife gets at least another call like that every month. That would be a slow month. I think you know my wife, who's now mostly retired, was a co-author of 5 Wishes and has a long history in advanced care planning. So between us, we get those calls. So the first question we ask is to try and understand just where our friend, family member, colleague is. Because 3-month, 6-month terminal is a lot different than, gee, I think my mom really is in the last chapter, but I think she needs to go to a nursing home. That's different than a 3 to 6 month terminal conversation. And this is only awkward because both of those are terminally ill folks.
Mm-hmm.
I mean, if you're ready to go to the nursing home, the macro data says you have 2 to 3 years to live. That's just the macro data. Now, you might live 10 years and you might live 30 days, but again, I can only deal in the aggregate data. But I'm just trying to tease out my reply to your question, because if my wife and I come to the conclusion that there's a chance you are hospice eligible, we have our own kind of screening tool that we use. And 75-ish%, I think, maybe even more, maybe 85% of the time, that ends up with us doing the 6 degrees of separation and calling Chris Como or calling, you pick the person in our broad extended network. But that means 85-ish% of the time, my wife and I conclude a nonprofit community-based hospice is the best organization to take care of our friend, family, colleague. And the reason we come to that conclusion has nothing to do with tax status. It has to do with, we believe that the 4 levels of care matter. So it's hard for me to get excited about working with an organization that doesn't do all 4 levels of care. There's lots of good reasons why patients are discharged alive, but if a hospice discharges 80% of its patients alive every year, that sort of hits my trigger around they're not going to be on the top of my list. I like to see, frankly, a bigger rather than smaller hospice, because I like to see that they employ at least some of their own docs. I like to believe that if 4 patients call on Friday night, they have enough nurses that they can see all 4. So maybe it'd be a whole other conversation one day. I could sort of share our family evaluation tool, how we do that.
That's actually a great idea.
But the bottom line is, it's not perfect. And you and I have kidded about this before. It's not perfect because I don't think we, the hospice movement now market, have done a good job in identifying quality metrics. So I'm subject to what's publicly available. I can only look at CAP scores or HIS scores or these other implied statistical measures like, discharge alive %, 4 levels of care, et cetera. I can identify if the hospice has a physician group and provides supportive care outside the hospice benefit. That usually also gets a checkbox, because all sorts of things could happen in terms of whether my friend, loved one, colleague is literally hospice appropriate that day. So that's not a hypothetical for me. And frankly, I think it's a great role play for hospice leaders, meaning I think it'd be great for you and your senior team to go through the exercise of, hey, if we all got a call from a loved one in Seattle, Los Angeles, Las Vegas, how would we decide who to steer them to?
That is great.
It'd be a hell of an exercise for a senior team to do.
Yeah, when we go into extended play, I want to tell you about a really cool project I got to work on several years back. It occurred to me when you were talking earlier too, Peter, senior living is going to become more and more place of domicile. And so do you believe that? Do you think it's going to become a lot more important for a hospice empowered care leader going forward, and why, and maybe what they need to be aware of related to that?
Yes. Have I ever answered a question that simplistically?
Tell me more.
I think that's a perfect example of the research that our colleagues need to be doing in their local communities, because, well, I'll give you an example. I first started looking at what we now consensually call the debt service ratio in the early 1990s. There was no internet. There was no way to get Medicare claims data. These were Freedom of Information Act requests to the CDC and to Medicare to try to get data about how many people were using hospice and, what all that looked like. So I've been looking at that data for 30 years. I mentioned in a slightly different context, if you go back to the early 90s, first of all, the debt service ratio was 7-8% aggregate. Now it's 50%. It was 0 in assisted living because no one died there.
Mm-hmm.
It was significantly lower than it is today in long-term care because you hadn't seen the proliferation of for-profit hospices until a decade later that really stimulated that business. I'm boring you with this because the senior housing market has evolved in ways that we sort of know and recognize, but don't. So as an example, the originators of assisted living were organizations like Hyatt and Marriott. This was going to be a hospitality play. This wasn't a healthcare thing. And you could imagine there was a whole bunch of smart people way back when that thought there'd be a Ritz-Carlton, a Marriott, a Residence Inn, an assisted living building. Well, it didn't exactly work out that way because hospitality folks realized as this became healthcare, that wasn't for them.
Mm-hmm.
Over the last 30 years, we went from hospice deaths only occurring in nursing homes, not at all in assisted living, to in much of the country today, that's 50-50. And I just looked at a few counties for some clients in the last week where it was 5-1 assisted living.
Wait, tell me more. 5-1.
There were 5 times as many hospice patients in assisted living as in nursing facilities.
Wow.
So the range county to county is extraordinary. Mm-hmm. And there's lots of reasons for that. And the analysis sort of template is uniform, back to 80-20 local, national. But every community is in a different place in terms of that evolution. And so I think doing a local map of exactly what's going on in senior housing is not something most of my clients have or have done. It's, again, more daunting than it sounds, you and I bantering on a podcast. It's a real piece of work. It's not so easy to understand who the owners of all these buildings are, because the owners of the buildings are oftentimes not the ones who run it, and the management company is different than the real estate investment trust. Well, this is our future, Chris. And a lot of my colleagues don't like it because they say, that's not hospice. I don't want to do that. Okay. I don't know what to tell you. You either have to keep up with our customers or fall behind. And so, again, I'm a little fearful, sometimes a lot fearful, that we're falling behind in understanding the evolving business models of our customers, because there are specialized ACOs that deal with long-term care facilities. There are specialized both MSSP and REACH ACOs that focus there. Obviously, we've talked a little about institutional special needs plans. The evolution of who's going to employ the doctors and NPs that go into that set of buildings is evolving and in flux. So kind of goes back to, I think we're in this 7 to 15 year inflection point, but with potential cataclysmic results for folks who don't want to change.
Well, and you just made me smile. That's why your friend Mark Cohen and I do our monthly podcast of the top news stories of kind of our way to say, hey, here's intelligence gathering. There's a lot of stuff coming because you're so right. Well, Peter, this is a question I really want to ask you. And so you and I were joking about our gray hair, our wisdom. You have a little bit more wisdom than I do. Actually, I have a whole lot more wisdom than I do. But if you were a young Peter Benjamin coming into healthcare, but you happen to know what wise Peter Benjamin knows, where would you advise that young Peter Benjamin to go make a difference?
I think about that a lot because in some ways it's the question I ask myself thinking about retirement. I think to myself, boy, if I'm going to work for a limited period of time, what's the most exciting place to do that? And so it's not so much a speculative question to me. And the answer I would give someone in their 20s kind of matches the decision I've made for myself in terms of I've never had greater reward than working in the broad end of life care area, because I think that the difference you make for people and their families is profound. It's not to minimize what else you can do in healthcare and the reward you can get, but I'm speaking personally, selfishly. And as I said at the outset, I think we're in this sort of amazing extended year inflection point. And so I think if someone in their 20s can identify an organization that, for example, has historical roots in a community and either already has or is evidencing not by what they say, but what they do, the ability and risk orientation to move from, for example, being a hospice provider to also owning a frail elder physician practice, or being in an ACO, or having a PACE program, or being a partner in a PACE program, or participating in an ISNP, or having a strategic relationship with an ISNP, if they can find an organization that they think has a fighting chance to come out the other end of this inflection point, I think they'll have as rewarding a career as I've had. And if we can't find folks who want to do that, then I think we'll be the worst, because organizations like yours need to be able to attract those folks. And we need to be able to not just tell them what we've done, but what we're going to do. And if what we're going to do only sounds like what we've done, a whole bunch of those young people aren't coming. And I think that's on us. I don't want to too shamelessly plug your book or some of your work, and you didn't ask me to, so I can say that openly and honestly. But I think the leadership challenges of the moment are greater than they've ever been in our line of work, because I think leadership is most tested in times of change.
Amen.
You know, I've kiddingly said to folks, I can say it with enough gray hair, closer to retirement, you know, I'm as guilty as any number of my colleagues that thought we were geniuses when we had tailwind.
I've never put it that way, but I've said it in a different way. That is so good.
And you only really realize how smart you are, or how good a runner you are, when there's headwind. And I think through no fault of our own per se, markets evolve and change. And traditional hospice now, I think, only has headwind to look forward to. And so either we find some related adjacent opportunities with some tailwind, or we suffer the consequence of headwind. And that's partly a market phenomena, but I'm more optimistic than that. I think that's on us. And I think that the idea of leadership starts with helping people see differently, helping people role play what their customers and competitors are imagining. And so I think that the emphasis that you've chosen to place on leadership is prescient and current, and be careful what you wish for.
We're just going to get to our quotes in a second. That was awesome, Peter. Well, any final thoughts to close us?
First, seek understanding. I think a lot of our colleagues are fast to judge and a little slow to take a deep breath and really try to understand what's going on all around us, and attempt, with good leaders, encouraging them, supporting them, holding them up, do the role play. If I got hired by an ISNP and that's how you were going to have to make a living, what would you do? If you got hired by a PACE program and that's how you were going to have to make a living, what would you do? Because I think in many instances, we'll learn from that forced exercise and we'll be the better for it.
That's well said. Well, Peter, thank you. And Peter and I chose a quote and you chose a quote. So Peter's quote will be first and then mine. And actually, I think is a great way to end this show. So Peter's is from a senior business leader executive at American Express. When you want something in the worst way, that's how you're likely to get it. And then mine was from George Lois. Creativity can solve almost any problem. The creative act, the defeat of habit by originality, overcomes everything. Thanks for listening to TCN Talk.